Hi, Terry Schoenfeld here from the UAB School of Medicine. In this video I'm going to describe clinical prediction rules and discuss their role in determining pretest probability and prognosis. Clinical prediction rules are just mathematical models that try to quantify the individual contributions of elements of the history, physical examination, and often basic laboratory tests into a score that aids us in determining diagnostic and prognostic probabilities. This is the Wells rule for deep venous thrombosis, or DVT. It contains several elements from the history and physical examination that were shown to be predictive of deep vein thrombosis. It doesn't contain all elements, though, of the history and physical that we could do. It only contains certain ones that were associated with the development of DVT. Also of note, the Wells rule does not diagnose a DVT. It just determines pretest probability of that DVT being present. And depending where that pretest probability falls on our disease continuum, we'll then decide if we need to do further testing or not. So why should we use clinical prediction rules? Well, I think there are three great reasons to use them. One is that our brains really can't weigh and take into account multiple factors when we're making diagnoses. We often put differential weights on one thing versus another. But clinical prediction rules can do that because they're just mathematical models. We could put as many things in them as we want, and they can handle it. Number two is that a clinical prediction rule, if you apply it to the same patient over and over again, will give the exact same answer. Not so with human judgment. We are often very inconsistent because, again, we weigh some things differently than others. We assign importance to certain elements that we think are important in the history or the physical that may or may not be. And this is really important for clinicians who aren't very clinically experienced, or for diseases for which we don't see very often and don't have a lot of clinical experience with them. They can help us be a little bit more accurate. And finally, that last point is that studies have shown that they're more accurate than us for many things. Again, because our brains aren't able to accommodate lots of things and weigh them appropriately, but clinical prediction rules can do that. So I hope we'll give them a try. They're used, like I said earlier, for diagnosis and prognosis, and all they do for diagnosis is determine the pretest probability. They never make a diagnosis of a disease. They just help us know pretest probability. Prognostically, they predict the outcomes of certain diseases for which they've been developed. So, for example, atrial fibrillation, one of the worst outcomes that patients can have with that is a stroke. Well, there's a tool called the CHADS-2 score that can help predict the risk of a patient with atrial fibrillation having a stroke. It doesn't determine if they have atrial fibrillation. It doesn't diagnose if they have a stroke. It's just used to predict the risk of them having stroke, and then we make decisions on whether we're going to anticoagulate that person or not to prevent stroke. There's several tools that we use pretty commonly in internal medicine. The ones on the left are prognostic clinical prediction rules that try to predict some outcome of the diseases, and on the right are diagnostic prediction rules that just give us pretest probabilities of these diseases. So I think prediction rules are most useful in two settings, and I've labeled them as complex decision making and high clinical stakes. So complex decision making is where we have multiple competing diagnoses that are somewhat difficult to sort out. So for example, let's say I had a patient who's had a history of a DVT, they have COPD, they have congestive heart failure, and they present to the emergency room with shortness of breath, cough, pleuritic pain. We examine them, there's some wheezing on exam, they're tachycardic. And so for me, in my mind, I'm really trying to consider, is this a COPD exacerbation? Could there be a pulmonary embolism here? So it's difficult to tease that out, so I might use the Wells rule for pulmonary embolism and see if this patient is at low, intermediate, or high risk of pulmonary embolism and decide if I'm going to further test for that or not. If they're at low risk, I might do nothing else other than a D-dimer, and if that's negative, I'll consider only this being a COPD exacerbation. So it's going to help me tease out this complex situation. Closely related to that is high clinical stakes decision making. If I miss a pulmonary embolism in that patient, it could be deadly for them. So clinical prediction rules will improve my accuracy at figuring out if there's something there I really don't want to miss. It really doesn't cost much to do a clinical prediction rule other than my time, so it's a quick and easy way to help me try to figure out what potential diagnoses could be there. What I don't need is clinical prediction rules in the setting of pattern recognition or simple decision making. So for example, if somebody comes in with a erythematous leg, it's warm to the touch, they have a little bit of fever, I find an entry source for infection, I know that's cellulitis. I don't need a clinical prediction rule to help me determine that that's cellulitis. So clinical prediction rule is most useful for very complex decision making. This slide shows the 3 steps of developing a clinical prediction rule. The first step is derivation, then we validate it, then hopefully we impact test it. So derivation, we just identify factors that are associated with the outcome of interest. Once we do that, then we have to validate that those factors actually predict the outcome. And there's 2 types of validation, narrow validation and broad validation. In narrow validation, what often happens is researchers will have a sample of patients, they'll split them in half, derive the rule in the first half, and then test it to see if it predicts that outcome in that second half. And that's okay, but we really like to see much broader validation, that it's tested outside of that clinical setting in broader groups of patients. And finally, what we'd really like to see is impact analysis. Make sure that the rule matters in clinical practice. An example of an impact analysis that was done for a commonly used rule is the Wells rule for pulmonary embolism. It was tested in the Christopher study published in 2006 in JAMA. And what they did is they had patients who were suspected of having pulmonary embolism. All patients underwent evaluation by the Wells rule. If you're at low risk by the Wells rule, you got a D-dimer. If that was negative, you got nothing else. And those patients were followed over time and found out nothing bad happened to them. They did okay. So this was a situation in which they made sure the Wells rule wasn't only dividing patients into low, intermediate, or high risk, but went a step further and made sure that if patients were at low risk by the Wells rule, nothing bad came from them. It impacted practice because it showed we didn't have to really do a lot of extra testing in those patients. It was okay just to follow them clinically. Another rule which has undergone impact analysis, the Ottawa ankle rules. They tested them in patients suspected of having a fractured ankle, and they found that if you were low risk on the Ottawa rules, you needed no further x-rays, and those people did fine. They didn't have any missed fractures. So make sure if you're going to use a rule, hopefully it's had undergone impact analysis, but unfortunately a lot of rules never undergo impact analysis. So how do we derive a clinical prediction rule? Well, you just come up really clinically with a list of potential predictors that you think are associated with the outcome of interest. Then you examine a group of patients and you see if the predictors are present or not in that person. And then you see what was done with testing to see if that outcome developed. Then you just put them into a variety of statistical models and see which of those prediction factors are associated with the outcome of interest at a p-value less than 0.05 or a p-value less than 0.01. And then you also want to make sure that they're very powerfully associated, because there are lots of things that have weak associations, but for one of these rules, we want it to be very parsimonious, and for each one of those things to be very powerful and clinically significant associated with the outcome of interest. Validation, we need to do validation because we need to make sure the rule really predicts what we think it predicts. Because a rule will always work in the group in which it's derived. That's just a fact. But what we need to make sure is that it works in another group of people who it wasn't derived on. And validation should be done prospectively, so we want it to start now and go into the future. We want it to be done in a new population, not the group who it was developed on. And we want this population to have a very different spectrums of disease. So what I mean by that is early disease and late disease. Diseases for which have similar symptoms that could be confused with the disease that we're interested in. So, for example, if I'm testing the Wells rule on COPD, the Wells rule on pulmonary embolism, I'd want people to have pulmonary embolism and to not have pulmonary emboli. I'd like them to have small pulmonary emboli, maybe more extensive pulmonary emboli. I'd like to have some other diseases that cause similar symptoms, maybe COPD patients, patients with pneumonia, patients with obstructive sleep apnea, etc. I want to make sure that the rule can really tease out the patients who do and don't have a pulmonary embolism. I also want it to be tested by different doctors. We got to make sure no matter who uses it, it gives us a good answer, and at a variety of institutions. We want it to be in academic centers, in community centers, in small cities, in big cities. We want it tested as widely as we can to make sure that it really does work. So in summary, if you're going to use a rule, really read about it, understand who it was developed on, understand its limitations. I see a lot of people take a prediction rule and extend it a little beyond the group for which it was developed and for the outcomes for which it was developed in. We don't want to do that because we don't know if it really works. Look to see if it's had impact analysis. If it's been shown to make a difference, you know you can use that rule reliably in clinical practice, and it'll make a difference. But importantly, use your clinical knowledge and make sure the rule makes sense and that it's easy to use. There's some rules out there that are difficult to use, like the Apache rule. So it's not as useful because it's very complex. We want things to be useful that are simple to use and don't take a lot of our time. This video has helped you understand more about clinical prediction rules and how to use them. If you have any questions, feel free to contact me through the course homepage or through the Contact Me section on my blog. Have a great day.